Session 2. The topic is Digital Health Implementation Case Studies. I would like to call upon Dr. Vijay Agarwal. He is the moderator for this session.
Dr. Vijay Agarwal is one of well-known names in Indian healthcare. He is a president of CAHO and has been one of the forces behind improving quality in Indian health sector.
Kindly go through InnoHealth's website to know more about Dr. Vijay Agarwal. And I hope everyone is taking pictures and posting it with hashtag InnoHealth 2022. The presenters for this sessions are Dr. Jaanus Pikani, having the presentation virtually. They have a recorded presentation. Dr. Jaanus Pikani is chairman of Scanbalt and Tartu Biotechnology Park. Dr. K. Madan is a senior consultant, healthcare NITI Aayog. And Dr. Sujoy Kar is a chief medical information officer and vice president, Apollo Hospitals.
To be here to share this time with you all. I bring you greetings from CAHO. CAHO is the consortium of accredited healthcare organizations in the country. Our DNA is to sensitize hospitals and healthcare providers to the problem of medical errors in the hospitals, and we work towards how do we reduce the medical errors. And there we find that technology and the adoption of the digital health is going to be one big game changer towards that end. The journey of the digital health in India, I would say, has just begun with the right drivers that are emerging. The Indian ecosystem represents an opportunity for the innovations, etc., or leapfrogging in this particular sector. The Indian government's renewed focus to achieve universal healthcare through the digitization of health records and technological advancements to enable digital cure will provide an impetus for the healthcare providers to digitize their services. I must say that the Ayushman Bharat digital mission backbone has been a great initiative of the government and is going to be a game changer for the healthcare ecosystem. What this Ayushman Bharat digital mission has done is you can compare it like it's like a highway of a digital highway that has been made ready. But understand that unless that highway gets connected with the end users, the highway will not be of much use. So we need what we are going to see in this session are a number of case studies which you will see in some of the previous sessions. Probably you were listening to things which may be probably going above our head for most of the times. However, the digital health is not merely about omniverse and metaverse and things like that. It is about absolutely day-to-day functioning and activities, and is going to very seriously impact. The problem has been that our healthcare providers and our community has not been ready. In fact, this pandemic to a large extent has made us ready, has made us accept the reality of digital health, of telemedicine. You can imagine that prior to the pandemic, telemedicine in our country was almost illegal. We from CAHO had also approached the Supreme Court along with the Telemedicine Society for India, and soon after that, at least the telemedicine guidelines have now come out. They may not be perfect, but at least that has made a tremendous change that from being illegal, now it is absolutely a legal entity to do telemedicine and to adopt to a lot more digital health applications. So I would say that, as I said, that the government has been playing a huge role, I must say, in this country, and one of the biggest thing which I see there is the interoperability. Their main thing has been that patients should be at the focus of this digital health, patient has to be empowered, and for that, their basic infrastructure has been slightly different from what you have seen in United States, where they are struggling now to see that how their health records or how their care can become interoperable. So in the panel, we have, of course, invisible here on the dais, Madan Gopal, but he has been held up because of something, but we have his video recording, and another example of how a digital thing can come to our rescue when somebody is not able to be present here. So we will listen to Mr. K. Madan Gopal, who is a very, very high functionary in NITI Aayog. He is a doctor, but a very important member of NITI Aayog. So I'll request you to please play this thing to let us know about the government policies, etc. in this field.
Grateful to the organizers of the 5th Annual International Healthcare Conference, InnoHEALTH 2022, for giving me this opportunity to share my views on the digital transformation in the country. Please accept my apologies. I have to join virtually because I have to be at other place as well. Please appreciate it. Thank you very much. We have all been exposed to digital health in one way or other way during the recent COVID pandemic, which is still ongoing, where many of us, we have used the Aayog app, or it was in fact mandated when we were traveling here and there. And we have been exposed to how that simple tool, by using mobile tower and the Bluetooth technology, how it was able to do the contact tracing as well as help us in the quarantine measures. The second thing which we got an exposure, we got to know, is which is now a public good, is the COVID app, COVID, which is it's a very complex IT app for managing the end-to-end of COVID vaccination, right from beneficiary registration, beneficiary engagement, scheduling, as well as logistics management and the certificate generation. That was a complex thing. The other things which we are exposed during this use of the virtual platforms, which has aided in monitoring and surveillance of many of the programmatic activities. So one of the important things which have happened during the COVID time is the use of digital thermometers and the digital pulse oximeter. In fact, these are the very important and very handy tools which have helped us in managing the COVID pandemic during the time when the system was overwhelmed for 2-3. Having seen the importance of this, the journey of the digital health in the country was not that simple. If you look at the digital landscape in the health, it's highly fragmented. We are having ICT systems across the spectrum, right from beneficiary identification and management, where we have the mother-child tracking system, RCH, strategic information management system, the SNCO program, IDSP program, NISHCHAY program. We do have payment information system, PFMS, ESIS, CGHS, ASHA software, PMJ, multiple and different this. If you look at the other supply chain management, we are having a EVIN platform. In fact, the EVIN platform has been customized and been upgraded as a COVID platform. We are having family planning, LMSS software, state level systems are there. We are having human resource management in the form of HRS, other national systems, state systems, birth and death registers, Aadhaar, state level records, hospital management system, state and private system. This gets further complicated with an equally fragmented private sector provider market in this. The challenges are that we don't have a single view of beneficiary. My information is collected for malaria, TB and other programs, but there is no single view of this. Apart from that, the data system which are weak, the masters of this, they don't talk to each other. We are collecting data by a peripheral most worker who is less qualified. And we are expecting a high quality data from that person. The capacities for data collections are also this, which is resulting into misreporting, because if you are having multiple sources of data, you obviously land up in this one. there's no level of accountability. The data only comes in one direction. It flows upwards without a feedback mechanism. Apart from that, no standardized format used for data collection, and hence they are not interoperable. Duplication of data collection, as I mentioned, you can appreciate that because so many multiple systems are there to collect information for a single person, then you will land up having this. Besides that, one of the important challenges which are there in this landscape is the lack of unique identifiers for patient providers, health facilities across the system. And to add to that, lack of common data analytics platform for this. If you look at the digital health initiatives in the country, as I mentioned in the previous slide, we are having an integrated health information platform for predicting outbreaks with advanced GIS mapping. We are having a hospital information system. We are having reproductive child health system for care and support to the mother and children. We are having Pikani mobile services to deliver. We are having online registration system. We are having e-Rapt coach. We are having TV monitoring system. And when in the Ayush system also, we are having an Ayush hospital management system, we are having Ayush Suraksha, we are having e-Charak portal, we are having National Ayush Mobility, we are having e-Aushadhi, we are having TKDL portal, we are having Tikanda Kosha, we are having Ayush Research portal. And what we are trying to do, we are trying to create a grid in which all these portals will be integrated and we can have a unified. We do have telemedicine in a telemedicine platform. The public platform is known as eSanjeevani, whereas there are other platforms also run by the private operators. In the public platform, the telemedicine in the health and wellness centers, where doctor-to-doctor consultation happens, which is currently actively rolled out in 11 states with 70 plus doctor hubs created by the state link with 3,500 health and wellness centers. Health and wellness centers, they are the peripheral most health institutions covering territory to a population of 3,000 to 500 population, wherein the screening facilities, the recruiting services, and 12 set of services are being provided to them. We do have telemedicine OPD for COVID management, and where the patient to doctor consultation do happen, which allows the registered medical practitioner to provide health services to the telemedicine. This digital health initiative has started way back, as I remember, in 2010-11, when the Clinical Establishment Act was enacted and was adopted by a few of the states. One of the para in the act was to create electronic health records. At that time, we had the vision to create electronic health records for 1.3 billion people, set up a telemedicine network, use of IT for a PAN network, pan-nation surveillance and monitoring of the program, using digital technology for capacity building and training, and deploying IT tools for governance and information dissemination. You will appreciate when I talk about how the journey has evolved into the Ayushman Bharat Digital Health Mission when we see the subsequent slide. To actualize that vision, we have created some institutional framework. These institutions were established. One is the Center for Health Informatics, which is at NIHFW, New Delhi. We have created National Center for Resource Center for Electronic Health Record, and the third one is the National Center for Telemedicine. These are all there. So, National Center for Health Informatics was created in 2013 by National Institute of Health and Development for managing the National Health Portal and other e-health initiatives. National Health Resource Center was created for HR, was established in 2014 at CDAC Pune to facilitate adoption and promotion of EHR standards in healthcare IT applications. National Resource Center for Telemedicine was started in 2011 at Lucknow to develop and strengthen telemedicine technologies and provide necessary technical assistance to state governments. To address the issues of silos, the fragments, and having a unified structure, we have made an intent in the form which is reflected in the National Health Policy. The National Health Policy envisions to have a digital health technology ecosystem and recognizes the integral role of technology, that is e-health, mobile health, cloud, Internet of Things, wearables, etc. in healthcare delivery. Para 23 of National Health Policy 20. With the policy enablement, we have started our journey towards having a national digital blueprint. The policy, as I mentioned, it has already envisioned to have digital health technology. When PMJ was launched, it was increasingly felt that with so much programs having so many portals, we should be having a technology stack, and through a common identifier, we can at least all the programs can be talking to each other. With that vision, we started the work towards having a national health stack. So in 2018, we released a proposal on national health stack that provided a framework for India's futuristic digital health system, specifying component required in the health IT programs. This was adopted, and subsequently a group was created. And this group made a recommendation which formed the basis for National Digital Blueprint. So in 2019, National Digital Group was finalized as an architectural framework for digital health in India for the evolution of national digital health ecosystem. So what does this National Digital Blueprint talk about? It talks about the national architectural framework, okay, what should be there. It talks about the converging disparate health information system. It highlights the importance of federated architectures and use of open standards. It has highlighted the importance of unique health identifiers so that the interoperability of the data can happen. It has mentioned about the privacy and consent management. It talks about the national portability. It talks about the electronic health records, applicable standards and regulation. It mentions about the health analytics and proposing the use of AI, machine learning, blockchain technologies. It talks about multiple access channels like web, mobile, telemedicine, digital health, India portal, My Health apps, etc. With all these efforts and work, our Honorable Prime Minister on 15th of August 2020, he launched the National Digital Health Mission to create unique health ID for each individual to provide access to integrated services across different tiers of healthcare service system. So what is the core of National Digital Health Mission? We are envisioning to have health IDs, we are having a DigiDoctor, we are having health facility registry, electronic medical records, personal health records. The core of the health ID is to be based on Aadhaar mobile number of the patient. It's a voluntary service to be availed by all the citizens. It is currently voluntary in nature, and slowly, with the increasing use, people will be coming forward. Then, trying to create a registry of the health workforce, the doctors and the nurses who are registered there. The health facility registry and ID is provided to the health facility, including labs, clinics, bloods. It is voluntary for the hospital to join. Health record are subsequently linked to the health ID because ultimately it is electronic health records which would be used for the data analytics and other things. Personal health records, you might be coming across now advertisement saying that how the personal health records become very important in case of medical emergency. So what problems and challenges which we have seen in the previous slides is Ayushman Bharat Digital Mission intends to solve. It is addressing the challenge of accessibility, affordability, and quality. These are the three challenges. How it is trying to address it, to what it meant for citizens. Citizens can discover the health services in the providers. They can book health services, order health products. They can avail video consultation. For the health providers, it can provide an access to view the patient health history. It can provide digital consultation to the patients. For the policymaker, we can view, analyze public health at national level as well as the state level and the local level. We can implement policies effectively at local level. So far, the progress has been quite encouraging and satisfactory. We have been able to create around 25 crore ABA IDs. Around 1.6 lakh health facilities have been registered, and around 90,000 health professionals have been registered with this. Of the 25 crores, around 1.14 lakh health records have been linked as an electronic health records. And this is now multiplying exponentially in the coming days. So with the policy in place, with the digital architecture in place, with the mission which is being implemented in mission mode, there are many opportunities and they are trends. There is increasing use of IoT devices. With 5G coming, you will be seeing a lot of changes in how the healthcare is delivered. We are increasingly using blockchain technologies in healthcare. Telehealth we have seen now with the help of 5G technology. Uh, we would be seeing more of the remote ICU and the patient management. There are many web portals for patient now. You will be seeing increasing apps for rating the providers and other people. Telemedicine is there with the release of the telemedicine practice guidelines. Now you are having lot of telemedicine. In fact, in the public sector also you are having a portal which is e-Sanjeevani. Whereas in the private also this, we are trying to see that how we can Uberize this telemedicine providers so that 24/7 telemedicine services are provided, and this telemedicine can result into continuum of care. That means after consultation, if hospitalization is required, they can be linked to the hospitals and they can avail the services. You have come across many mobile apps, and this you will be increasingly seeing that. And use of artificial intelligence for this. You have seen increasingly how the Google is using the artificial intelligence. Once the network and the records are being generated, you will be seeing the increasing use of this. In the end, I just want to say that we are moving in the right direction. We are having the ecosystem, all the prepared, starting preparations are there in place, and we are moving in the right direction. With new technologies, we overcome the existing challenges and optimize the business processes. We need to adapt to the rapidly changing digital world and use technology to improve efficiency. One thing which we should remember before I close is identifying the problem or opportunity and determining how technology, including future technology, will solve it. But more critically, how it won't. We should always keep this in mind. Thank you very much for this opportunity. Thank you very much.
So I'm sure that this was a very, very informative talk by Mr. K. Madan Gopal. But what I would like to just clarify that none of the services are being provided by the Ayushman Bharat Digital Mission directly. It is not that they are providing telemedicine or they are providing that. Please understand, that's only, as I said, it's only a backbone through which we are now needing a lot more people to get connected with them. So it's like that the track is ready or the engine is ready. We need people to come forward, whether it is telemedicine providers or whether it is the many other aspects of the digital health. The thing is that if they would not have come, then it would have remained fragmented and would have been a great problem like it is there in the rest of the developed world. So this particular backbone is for taking this initiative and making this happen. But now is the time for the private sector and for all other vendors and everybody to come forward and be a part of it. And the examples of that are going to be huge and huge. And today we'll see some of the examples here. We have Mr. Jaanus Pikani, and he is going to talk about a model where they are using digital health to address the issues of mental health. So over to you, Jaanus.
Thank you very much. And I would start from the So I will start where I stopped in the original session, that in the Scanbalt we have I would start where in Scanbalt we have a special devotion to the digital health and data. If we speak about data exchange, then the European Union as a general is pretty much in the same situation we're in now, because union that contains 27 member states, actually the member states' health systems doesn't speak with each other. because health has been, until now, actually responsibility of each national member state, not as it was shown today that in Estonia all health records data which are time critical and the imaging diagnostic lab data are actually can be reached wherever you are in the world. If you have authority to reach, or the person can reach his or her data through this we call it a patient portal, where a patient can actually reach the data immediately if they have delivered from laboratory, for example. But the situation is actually in Germany, for example, totally different. Their hospitals are not talking to each other. And just yesterday I had a presentation to a group of people who actually were gathering in Belgium to actually promote this data exchange in healthcare in the region. So this is just to give you an understanding that. But the other thing is what kind of tools we have, really digital tools, to actually support clinical activities. And here we might have a different situation in different types of work, because these two things are not always connected. You might have extremely well advanced digital diagnostic support tools, but they are just used in a specific clinical setting or in one hospital, and the data are not going over to others, but still they are very useful. So I would like to talk now about one example, which is now in the phase of starting to clinical application. And this is actually a tool which actually is addressing mental health, which is to help healthcare systems, primary healthcare doctors, mental health nurses, as well psychologists and psychiatrists, to improve quality, accessibility, and efficiency of the work. And just how we see and what is a reality in the world, that there is about 1 billion person in the world globally that actually have some kind of mental health problem. So this is, we call it epidemic. And it has been said that the global cost for mental health is increasing to nearly 5 trillion by 2030. This is actually estimate is done before the war in Ukraine, which has increased this tremendously, at least in Europe. There is, at least in Europe, and especially, for example, in Estonia, there is 3 to 4 months waiting time to get to the consultation with the psychiatrist. And unfortunately, primary health doctors are not very capable to deal with this field of medicine. And what is the problem? What has been actually brought out is that even if the person gets to the the psychiatrist consultation, then it appears that the decision on the diagnosis and treatment is made in first 5 minutes, not structured way that to look and assess thoroughly the patient, which is actually needed by the ICD-10, for example, which prescribes the criteria for diagnosis, and the documentation. Very often the documentation, what the visit notes are very superficial, and this has caused a number of problems and caused the litigation. and also it actually refers to the quality of the treatment and diagnosis. Because if you cannot actually document, then how you can actually be sure that this outcome is correct. So this why this solution has been created. And if to just give you a couple of data which is fresh, just last week the OECD published a report on European health at glance, which has such a part of the mental health, and this is actually a result of the COVID-19 pandemics, which actually says that, for example, in Norway, for the people age group 18 to now 29, it has increased tremendously. And I mentioned already the Ukraine, that it has been estimated that at least 10 million person at the moment has some mental problem, which has increased and has not had this before. So what is proposed, and this is actually developed by a professor of psychiatry. He has been working also in Imperial College London, but now it's back in Estonia. It's developed for 10 years. And it's based on the actually digitalizing the ICD-10 fifth chapter criteria and building on these criteria algorithms. And using the questionnaires which have been approved by professional bodies to actually collect the data and feed in the data. And this consists of two parts. One is a simplified part, which is actually an app, which is meant for layman. Persons can actually fill in 15 minutes, 10-15 minutes, and then the system gives sort of suggestion, is there any deviation from the normality and or severities, and what kind of treatment or consultation the person, either psychiatrist or general practitioner or psychiatrist. And then these data are already in the system, and the specialist can continue from this, what is fed in by the person. And this assumed the mental health status as described, that the system proposes a diagnosis. When doctor approves the diagnosis, it suggests treatment modalities, and then creates documentation. It can be done in seconds. So it means that in our Estonian experience, if normally the doctor will take a psychiatrist is taking like 1 to 1.5 hours for first visit with a mental health patient. This system allows to do this everything much better quality in 20 to 30 minutes. And if there's still 1 hour consultation, then the rest can be devoted and used for the psychotherapy. So this part is free, and this is actually charged according, I will tell it later. So this is what the patient will see, like different, the matrix with different fields of mental health, and then this, what is the gray means that there's not enough information, and the green means that everything's okay, and the yellow is moderate deviations. So for patient, it gives opportunity and possibility to be more empowered and engaged, because the patient can actually evaluate every day or 10 times a day, because there's no difference. And the only if there is a sort of suggestion and patient accepts the proposal, then there is a possibility to make appointment online, and the patient then has to, in a Estonian case, has to identify itself with the ID number, and then it will be personalized. Before that, it will be anonymous. And of course, when in remote areas, especially if patient comes from far from the big cities, it helps to get because the consultation, 99% consultations with the consultant or with a specialist will be actually online, and it is much more affordable. So for mental health clinics, as I said, it increases quality. For primary healthcare, actually, to doctors, it enables them to do what they cannot do today, because it's like a psychiatrist in their office, advising, which usually you get only if you send patients to the secondary consultation. And the problem is that they are not able to make any proper assessment of patient, description of patient, and that's why e-consultation, for example, which is very popular in Australia and other fields, is not possible, because if doctor doesn't have any previous information on the patient, it's the only way to get the patient to the consultation and ask the questions by himself, herself. So, and what is for public health? As I said, it's accessibility, efficiency, and what is important that this patient part is actually helps to stratify patients to the right specialist, right level of care before they actually making a point. Yeah. And as I said, revenue is fee per each patient, like 10 to 20%, what we are exercising now. And big clinics and insurance providers, they are actually special cases, which for actual tailor-made contracts. Where we are now, this has been evaluated and validated by 15 countries, specialists. We launched a year ago the service in Estonia by mental health clinics. And now it's in Estonia, there's about to launch a project with a number of primary health clinics, specialist clinics and psychologists involved to actually measure this efficiency and how it actually can be used in a bigger settings and how it can be connected to the Estonian e-healthcare system. And also we have been using this for forensic purposes, like for forensic expertise. It's very well received. And what is more, if we go back to the Ukrainian war, there is actually launched the Ukrainian version, language version, which is actually means that the Ukrainian doctors who are now located in Ukraine and psychologists are starting to use this online. Of course, they don't nowadays always have internet, but Elon Musk is hacking them in some way. And still the idea is that wherever the Ukrainians who are actually suffering from the war are situated and located at the moment, because there's a lot of refugees are, for example, in Poland. In Estonia, we have 60,000 for 1.3 million population Ukrainians. In Poland, they have close to 5 or 6 million. They said like 10 million refugees from Ukraine today. And as I said, at least 20% of them has a problem. So this is now about to launch this system. And of course, in UK, there is some initial contacts. So that is what we're all, I understand that this was a bit technical, but it was very clearly seen that what you can do even without any major sort of, connected e-health system, of course, e-health system helps us. And in Estonia, of course, we have this already in place. And the other sort of benefit what can we get here is you get the very well actually structured and standardized data, which can be used later for federated learning, AI, real sort of intelligent AI systems where self-learning system and improve the system and add pharmacogenomic components with also visual emotion detection by machines. Thank you very much. I'm happy to answer the question.
Got consolidated, and Estonia probably took a leadership role much before. So the data exchange, that the frameworks that are put in place, are they moving to FHIR or are those HL7? Can you maybe share some details about the technical frameworks that are being used?
In the sector as a general in Estonia, you mean?
Yes,
because this is a self-standing. This is not actually integrated to any system. This system, what I described. This is integrated in a way that if the documentation has been produced, then in Estonian practical world, this PDF or Word format document, or you can have in other format, is actually transported to the general system of Estonian or this particular hospital healthcare system as a document.
And the hospitals also.
But the hospitals have excellent 7. And I'm not a specialist, but I know that they are working on SNOMED.
Okay.
SNOMED is now what is actually Estonian e-health institutions are working to go on over to the SNOMED.
India is also on SNOMED, and I think ABDM is based on FHIR, so we'll be very keen to explore and discuss.
But if we continue, of course, we can discuss it with the Taltech, where your director was visiting. There is also a department of e-health, and they are especially dealing with this and the institutions. So if you visit us, we can actually discuss it.
Thank you, Jaanus.
Thank you, Jaanus. It was an excellent kind of a showcasing how such an important medical problem is being dealt now through the whole system of just an app and AI. And what you are getting at is that this is not going to limit only to mental health. Let me tell you, all medical problems, sooner or later, are going to get to this route. Probably the doctors, if they feel they are threatened, I don't think that probably is going to be the case very soon. However, I do feel that a second opinion from an app may become a necessity. You see, the amount of the explosion of the knowledge is so much today that it is impossible for a human mind to comprehend and compute everything that is kind of going on. And that's where he needs to take help of these kind of clinical decision support systems, and many more such apps are going to be on the way. So thank you very much, Jaanus, and I think things like this, what you're doing in Ukraine, the refugees, and same way I would say that a large part of our population needs this kind of a help. We have to see how to kind of get that help to them almost at no cost. That is the big kind of a question that we have to solve. That how do we make this kind of a service available to people and make it very affordable? Thank you. Now we come to the last part of the discussion, to my third invisible panelist here, Sujoy Kar. He has also gotten not well, and that's why he will be again making a kind of a video presentation. He is the CIO and the Vice President of Apollo Hospitals, and I can say that the application of the digital health, you can take an example today that, for example, the nurses are today taking your vitals, pulse, blood pressure, so on. You just saw at the entrance of the hall, there is a machine there called Pulse. And there, of course, on an outpatient basis, somebody can just stand up on that machine, put his hand in there, and the machine is giving you all his temperature, pulse, etc., SpO2, everything is giving there. Now imagine that if all the patients who are lying in the hospitals, today there are products which are coming up where a certain amount of patch is being put or certain sheet is being put under the mattress, and the the pulse and the respiratory rate and the blood pressure of the patient is, if it can be monitored and automated, you can see the amount of time that the nurses will save. They can then spend that time much more in the human, for human interaction. And the errors have been shown to be reduced by these kind of automations. So I'm sure that Sujoy Kar, who is the Vice President, as I told you, of Apollo Hospitals, is going to showcase how digital health is being used at Apollo Hospitals. I would like to conclude this session by saying that, all the same, let us not presume that digital health is going to take us to universal health coverage without real infrastructure presence all over the country. That is totally lacking, and we need to move that along with this entire thing. The two things are inseparable, and therefore sometimes what we feel is as if digital health is the only solution. That's not the only solution. Thank you very much, and we'd like to
Thank you so much, sir. Definitely, never knew technology will be a great impact on healthcare. I would now request Dr. Jaanus Pikani to felicitate Dr. Vijay Agarwal.
Please welcome this with a loud round of applause. Session by sir and speakers and our moderator Dr. Vijay Agarwal sir was a very informative session. Especially insights on Ayushman Bharat, how it's changing the dynamics of healthcare in India, and whole world has recognized it. Please give a loud round of applause.